Okay, we're now going to turn to a very exciting area, both for diagnostics and treatment of imaging and Gallium-68 and PRRT. And we have two speakers there. One principal speaker, Dr. Ebrahim Delpassand, also from Houston, Texas, who's going to start us off. And then Josh Mailman, who many of you know, is going to provide some comments and perspective from a patient perspective. And then we'll move on to the next piece. So Dr. Delpassand.
Thank you, Ron. It's a great pleasure to be here. I would like to thank the organizers of this meeting, Caring for Carcinoid Foundation, as well as Cedars-Sinai. Thank you so much, Dr. Hennifer, for your invitation. I know the time is kind of limited, so I go dive into this and tell you about PRRT as well as Gallium-68 dotatate PET CT imaging, two modalities that are done in the nuclear medicine specialty, basically. For our patients, these are my disclosures. I will talk about the principles of PRRT, studies of PRRT in US, and also studies of Gallium-68 dotatate or other analogs of somatostatin receptors in US, and the clinical trials and regulatory approval of these. Just a quick question, any of you who have received PRRT in the audience, how many of you have received? And how many of you are thinking of PRRT? Okay, that's great. So I try to give you a sort of a snapshot of this, if you will, because the time is very limited, but I'll be available to answer any of your questions after this meeting. What is targeted radionuclide therapy? This is what we think is a personalized therapy, because we carry therapeutic radionuclides, radioactive materials, to a malignant site, specifically to the malignant site, as much as can be specific, to deliver the lethal radiation dose to the tumor with minimal or reversible injury to the normal organs. There's certain important things in here. Number one, therapeutic radiopharmaceuticals. Not all the radioactive materials they have therapeutic capabilities. I'm going to talk about this in one slide to tell you what kind of radioactive materials we have. And then it has to deliver enough radiation, so the amount of radiation is extremely important in order to cause deadly effect on the tumor cells, which we think it's by breaking the DNA. DNA has two strands, and in fact, if a radioactive material can break both strands of the DNA, there's going to be irreversible damage to the tumor. And also at the same time, we need to keep the normal organs healthy, or even if there is a temporary damage, it can resolve and recover itself. There are three types. The one on the bottom is the gamma rays. These are used mostly for imaging because they have a very long path length. They can get actually outside the body, and if you put a gamma camera on the side, we are able to image it. There are two types of radioactive materials that are used for therapy, betas and alphas. Beta, they have a certain tissue penetration ranging from 1 millimeter to more than a centimeter, and the alphas are another source, particles, radioactive materials, that usually they have a very limited path length in the tissue, and they are extremely energetic. So we said it's a targeted therapy. We target somatostatin receptors in the case of neuroendocrine tumors, and in this slide, I wanted just to show you another characteristics of radioactive material, and that is the crossfire effect, meaning that even if the blood supply to some areas of the tumor, they are not rich, still since the radioactive material can travel in the tissue, it can damage the rest of the more hypoxic or ischemic areas of the tumor. This slide shows the number of somatostatin receptor, the percentage of expression in different type of neuroendocrine tumors. Our therapy or diagnostic studies are based on reaching to these receptors. So if a tumor expresses higher level of somatostatin receptors, we have a better success in identifying those tumors as well as treatment of those tumors. When the radiopharmaceutical, which consists of a radioactive material, a chain or chelating agent that can attach the radioactive material to the side of to the molecule that carries the radioactive material, it can reach to the tumor, it can be absorbed by the site of receptor and then internalizes. Internalization is believed to be very important characteristics of these molecules because it takes the radioactive material very close to the nucleus of the cell, that the place that we have the DNA of the cell, and DNA is responsible for the growth of the tumor and all the function of the tumor. Here I have one quick 2 minutes video. If you can start it, just tell you very briefly how the PRRT works in our patients. If we can have sound, please. As you saw, this is a lutetium, this radioactive material bound in the chelating agent, and the molecule, which is the peptide that we have. It emits both beta and gamma, so we can use it for therapy as well as imaging at the same time. It is injected intravenously into the patient, as you can see now. When it gets into the bloodstream, it goes and finds the tumor cells, attaches to the tumor. This is an example of the tumor. Blood supply brings the isotope radiopharmaceutical to the side of the tumor. And then peptide looks for those receptors, gets into the receptor, internalizes, goes inside the cells, and therefore can reach to close to the nucleus of the cells. And then this causes destruction of the tumor. All right, you can stop it now. Thank you. So this is a typical infusion therapy suite that we have. We do these therapies in an outpatient setting. There is a dedicated gamma camera next to the infusion therapy suites. These are obviously private rooms. Patients, they stay there until the therapy is completed. Our technologists, through the TV closed circuit, they can watch them, and if they need anything, they can respond to them quickly. Imaging and dosimetry is done right in the room next to them. And here, I wanted to talk, we have talked about the multidisciplinary approach. It is extremely important to have all the specialties sort of helping the process. Of course, patient is in the center. We have a clinical therapy coordinator that her function is extremely important in communicating with our patients, with the referring physician's office, and internally with our own team. At the same time, we have to have our support since this is done currently as under investigational new drug application. We have to have our research team. We have to have a team that can respond to IRBs, institutional review boards, to FDA, etc. And also a group of radiochemists, people who can actually make this drug for us and deliver it to the clinic. At the same time, we have pathologists, interventional radiologists, radiation oncologists, as well as physicians who can manage the pain of the patients and also manage their diet, etc. So as you can see, patient is in the center, but we have all these different specialties that they need to be available in order to have a successful program. These are 3 radioactive materials, radiopharmaceuticals that are used for PRRT. Indium-111 is one, yttrium-90 and lutetium-177. These are all different kind of radioactive materials with different tissue penetration, but essentially they are attached to the same molecule that can take these radioactive materials like a vehicle to the site of the tumor and attach to the somatostatin receptors. We initially started in 2005 with high activity indium-111 octreotide. This was 500 millicurie 4 times. Majority of our patients actually were able to achieve a stable disease after this therapy. We had a couple of publications related to this. And then, like our colleagues in Europe, we started moving toward Lutetium-177. It took me about 3 years to take it through FDA, but finally it was successful, and we started our trial in 2010. So we have been doing this now for 5 years. Our protocol consists of 4 cycles of 200 millicurie Lutetium-177 dotatate that we give every 6 to 9 weeks. We typically start with kidney protective agents. Since these radioactive materials are excreted through the kidneys, we have to protect the kidneys against the radiation. So we have a special protocol that we start amino acid infusion about 30 minutes before infusion of the radioisotope, and then continue for 4 hours. We typically do dosimetry. At this point, we are doing only dosimetry for patients with high blood pressure and diabetes, because they have a more sort of a predisposing factors related to kidney toxicity. FDA later on allowed us to do 2 more therapies in patients who achieve the stability for 6 months at least, and they show any sign of progression. We were permitted to give 2 more cycles. A typical consultation it starts initially with receiving the information. So if your physician is interested in this, if you are interested in this, you need to send us basically the most recent clinical information that you have. If you have any results of the reports of the pathology is needed. Also, especially the results of your Octreotide scan or Gallium PET CT, if you have it, is extremely important for our decision making. And then, if everything sort of makes sense and we think that you are a good candidate for these therapies, we invite you to come to our center. And a typical procedure starts with actually a video that we have prepared. After hundreds of times repeating ourselves to our patients, we decided to put together a video that will give all the information to the patients, and then we can actually spend more quality time with our patients, answering their questions and trying to elaborate on some of the points in the video. So, and right after that meeting, our nuclear medicine technologists, they talk to you and they give you all the do's and don'ts after the treatment, and they can answer your questions as well. And our scheduling people also, they meet with you at the same meeting to schedule you for your next treatment. These are the typical tests that are needed, a combination of structural imaging studies as well as functional. And as you can see, the list is in here. We also check for renal function, for heart function as baseline, and we do a whole body bone scan. We published our first report on first 37 patients who received the treatment. And here I have the most recent results actually related to our therapy. Recently, FDA requested the cumulative report from us, and we started basically putting all our data as of mid-May of 2015. FDA told us we don't care that the patient has received 1 therapy or all 4 courses of therapy. We need to see the results on the response rate. To us, it was unfair. It's like you have a course of antibiotic that you need to get for your sore throat for 10 days, and if somebody just take 2 of those capsules, this doesn't mean that the capsule is not working, but they didn't take the whole course. But we said, okay, we will do that. And this is the results when we look at all patients, whether they received 1 cycle of therapy or completed the 4 cycles. In this group of patients, we were able to control the disease. Control the disease is defined as achieving a stable disease, partial response, or complete response in 62% of our patients. When we look at the one that actually completed the 4 cycles and we had a 3 months follow-up, our results are actually astonishing. We have about 90% stable disease with objective response of about 22%. A stable disease in this group of disease and patients is very meaningful. We think is clinically meaningful. And by the way, these are all patients who had previously progressive disease, and they had tried all the conventional therapies before coming to us. So these are complicated patients and proven progressive disease based on the RECIST criteria, which is a diagnostic radiology criteria. And these are our survival curves. As you can see, this is a progression-free survival comparing the patients with complete response, partial response, a stable disease, and also we did something else, and we put the light blue one is actually everolimus PFS as compared to the group of patients that underwent PRRT, and as you can see, there is significant advantage in receiving PRRT as compared to everolimus. And this is another one showing those patients who actually received all 4 cycles and had a 3 months follow-up. So altogether, how long this effectiveness of the therapy lasts, this is our results again. If the patients, if we look at all patients, the PFS at this point is 14.5 months. If we look at the patients who have more than 2 cycles of therapy, the PFS is 16 months. As you can see, the upper range is several years, actually. So we are very pleased to see these results, and the evaluation actually continues. What happens to patients who are symptomatic? This curve shows that these patients actually, a majority of the patients, between 53% to up to between 53 to 70% improvement in their symptoms such as abdominal pain, diarrhea, flushing, fatigue, and weight loss. So these are in terms of symptom relief and improving the quality of life. This is what we are seeing in our patients. What kind of a toxicity we have? The toxicity is actually very mild. We are not seeing any grade 3 or grade 4 toxicity as it relates to the kidneys. We were always worried that since kidney is going to get a high radiation, we're going to have a problem. But with kidney protective agents that we are using, we are not seeing any grade 3, grade 4. Just one thing, I mean, usually grade 3 and especially grade 4 are the ones that we get anxious, and these are serious adverse events. So as long as side effects are grade 1 and 2, usually they are very well manageable. Many of the grade 3s are manageable as well. In terms of hematological toxicity, we see few grade 3 and grade 4, but the duration, as you can see, is something like 2.7 months or 0.9 months for the grade 4 hematological toxicity. For hepatic toxicity, no grade 4. We have had few grade 3s for the duration of about 3 months. So these are a majority of the patients. They tolerate this treatment very well, and the side effects are nothing close to chemotherapy that we see in many patients, that they get sick, they get infection, they get bleeding, etc. So this was one patient. I wanted just to show you, 64-year-old woman who was in good health, actually, had a virtual colonoscopy, and during the colonoscopy they saw liver lesions and they saw a pancreatic mass. So it was biopsied, it was neuroendocrine tumor. She underwent a resection of the tumor in the pancreas, and then radionuclide hepatic embolization, and then she was referred for PRRT after progression. This is on the left is the Octreotide scan before the therapy, and On the right, lutetium after therapy, we get imaging, as you can see, in the middle of the mid-upper areas of the abdomen. There is a significant increased uptake, and also in the liver. Upper row is the PET scan before therapy showing the lesions in the mid-upper abdomen and liver. And then the lower row, after 2 cycles, actually, we see a metabolic response. This is while actually still their CT scan shows lesions, but metabolically, these lesions, they have stopped functioning. So what's going on in US right now? It is very interesting what's going on. Number one, we had a randomized trial for lutetium that completed enrollment in January of this year. So all the patients needed for that trial has been enrolled. There is one sub-study of that protocol that is going on at our center as well as Stanford. That's for dosimetry, doing for dosimetry part of the lutetium therapy. So we can still enroll patients under the sub-study for this project. Our own IND, which was active since 2010, in February, I requested FDA to allow us to treat more patients. We have been reaching to 150, which was the original sort of authorization by the FDA. And then, although we submitted the request in February and they are supposed to, in 30 days, to get back to us, we didn't hear anything from them. So we thought that, okay, it's approved. But in April, I got a phone call from FDA. They requested a phone call, and we talked to them, and they said that, oh, we don't agree with increasing the number. So we tried to respond to them. Our response was filed a week ago, so we are hoping that by July 22nd, we hear from them and we can resume our therapy for lutetium. There is another thing going on in the state of Texas. We have a Right to Try Act, which is essentially allows any patient with terminal disease, they define cancer, any cancer as terminal disease, which for many of us, and you know that it's not terminal, there are lots of options. But overall, in the state of Texas, we'll be able to offer these investigational therapies that are not commercialized yet to our patients. So this is going to be another option. We try to go by FDA as long as we see the cooperation, but I can tell our patients that this is another option that we will look at if it is necessary. So this is the status right now. We are waiting for the approval of the lutetium-177 dotatate. Hopefully sometimes in 2016, we think we should have approval by this. Of course, nobody can predict FDA. What futures brings is we want to treat our patients at an earlier stage. We want to do the protection of the normal organs, such as kidney, so we can treat with the higher dose. With any cancer, you can give enough radiation in a targeted fashion, you can kill it, but at the same time, we have to make sure that we don't create more damage for the normal organs of the body. Combination of different type of radioactive materials is very enticing and very interesting. We are especially interested in alpha therapies, which I have a couple of slides to show you. And also there are new analogs that are coming, which are antagonists for somatostatin receptors that are hopefully is going to be very effective. So this is the antagonist, much higher on the left side. You see the indium octreotide scan, and on the right side, these antagonists, as you can see, the lesions they show, they are a lot brighter, and it tells us that they are expressing, they are more active with this ligand, the new ligand. These are a couple of examples. Again, on the left, antagonist versus on the right, lutetium dotatate. That's the one that we currently have. And a more exciting one is the alpha therapy. Alphas are extremely powerful. My physicist tells me that if the destructive sort of capability, if you want to compare it, a golf ball going through the glass versus a Honda Accord going through that. So it is extremely powerful, but at the same time targeted. They are the tissue penetration for alpha emitters are very short, and therefore hopefully the side effects are going to be a lot more controllable. At our institution, we are starting this actually, and we are hoping to have the clinical trial, first phase 1 clinical trial, hopefully by the first quarter of 2016. This is an example of one of these therapies, which was the picture of the year at the Society of Nuclear Medicine meeting. As you can see, the increased uptake in the liver on the left image, and then disappearance of the lesions after alpha therapy. So this is what we are doing actually, as I mentioned, first quarter of 2016. We're gonna hopefully have our phase 1 clinical trial on alpha therapy. The alpha part is the lead-212, which is now available to us, and we can do our therapies. Quickly, I would like to talk to you about the Gallium PET CT. This is an agent that now allows us to do PET scan on patients with neuroendocrine cancers. These are the centers that currently are active in doing Gallium PET CT. Our center in Houston, Excel, does that. NIH, Stanford, UCLA, and Vanderbilt. They're using gallium-68 dotatate and gallium-68 dotatate at the University of Iowa, Mount Sinai Hospital, Mount Sinai School of Medicine, Memorial Sloan Kettering, and UCSF. So these are the centers that these are available. Josh can tell you the latest places that they are doing this. I think it's not difficult to say the difference. Look at the images on the left side and compare it to the right side. These are the images on the same patient with 2 days difference in terms of imaging. It looks like, on the left, looks like you are looking at a high-definition TV versus a 1960 RCA TV. So it is extremely clear, and with this we can really identify the lesions that previously with Octreoscan we were not able to do that. Of course, adding the CT, which is anatomical imaging, to this makes it a lot easier to interpret and also look at the location of the lesions in the body. So this agent has a significantly higher spatial resolution, the contrast resolution. We can actually measure the activities. Since it's a PET scan, we can calculate the standard uptake value, which is extremely important for us to know the receptor expression and also compare pre- and post-therapy images and have a number actually to rely on, which is very important. The entire Gallium PET CT scan is done in 2 hours, while, as I'm sure many of you have done Octreoscan, it takes probably 24 hours or even 48 hours sometimes to complete. Less radiation, although it has a CT component, combination of Gallium-68 PET CT still has less radiation than Octreoscan, and of course, co-registration is very important. This is our preliminary data on 90 cases that we looked at, and you can see the number of lesions basically identified by gallium dotatate as compared to indium DTPA. As you can see, these lines are all up. We saw more than 3 times lesions, cumulative lesions, when we added all the numbers. And the red column over there shows the p-values or statistical significance of the lesion detection between gallium dotatate versus indium-111 DTPA. So we think that the gold standard is losing its G very soon. And we're going to have this as a basically available modality in all centers. So I would like to thank you, all our collaborators in here, and my team at Excel Diagnostics and Nuclear Oncology Center in Houston, and I'll be available to talk to you if you have any question. Thank you so much.